Okay. There's something on the top. Still they are joining.
So next time when you're conducting a meeting, if you set up a password, you wouldn't have to admit them one by one.
Ah. So I thought just ignoring the password would allow anyone to join the meeting. Right. So are they still waiting now? Oh, I will start, right? Okay. Right. Okay, now this, so I have prepared basically 8 questions, right? And then 1 to 8. And now I will name one person from each group to answer the question, right? I will do that randomly, right? So now all these questions are based on pneumonia and complications and complications of pneumonia, and then different types of pneumonia, right? So all these you have to exclude all these patients are not having any kind of COVID-19 infections, right? So they are without COVID-19, right? Pre-COVID-19 era, right? So we will begin with the first question, right? So this is the type of question you will get in your final MBBS SCQ paper, right? So a 68-year-old man presented with cough and fever for 3 days, right? And there is a past history. Patient has been having diabetes mellitus for 10 years, right? And in addition, patient has been consuming alcohol regularly. On admission, patient was febrile, saturation 88% on room air, and his respiratory rate was 38, pulse 112, blood pressure 80 over 50. And now there are, on auscultation, there is bronchial breathing and post crepitations heard over the right upper and mid zones. Right? So what is the most likely clinical diagnosis? And then you have to comment regarding the severity of his condition. So can someone from group 1, so I hope that group 1 is from 1 to 20, am I correct?
Yes, sir.
Right. So I will randomly pick someone. Number 16. Is that person available? Dasya. Number 16. Patrick, can you hear, my dear?
Yes, sir. Yes, sir.
Huh?
Yes, sir.
Can you hear, Puta?
Yes, sir.
Oh,
I
who
can
is
hear.
number 16?
He is not there, sir.
Right. So then number 12?
It's me, sir.
Ah, very good, very good. Right. So what is the most likely clinical diagnosis in this patient? Now, patient has got coming with cough and fever, and the lungs, basically there is bronchial breathing and forced crepitations over right upper and mid soles, right? So what is the most likely clinical diagnosis in this patient?
Right side upper and mid sounds pneumonia.
Okay, so right upper, or so we have lobes, it's either right upper lobe or even it can be even right middle lobe pneumonia, right? So you have to mention the site and then the site and the area as well. So why did you say it is pneumonia?
Because
What were
patient
the
presented
clinical signs on the test?
patient presented with cough and fever, and his febrile and saturation was 88, and respiratory rate is increased. Also, he has bronchial breathing with hoarse crepitation.
Right, over right upper and mid soles, right? So now clinically, right? Clinically, you have to comment about his condition, about the severity. What do you think? Is it just mild pneumonia, or is it severe kind of pneumonia?
We have to apply CUP 65 viscose. Then
right. Okay. So what is CUP 65?
There are 5 areas in confusion and urea level more than 7, and respiratory rate more than 30, and systolic blood pressure less than 90 or diastolic blood pressure less than 60, and age over more than 65. And in that score there are
65 score.
It's 3, sir. So it's a severe pneumonia.
Right. It's 3. Right. So even we haven't done the blood hematological investigations yet, but still with the other 4, patient has got 3 out of 4, isn't it? So patient has got severe pneumonia. Okay. Right. And then so right. So then I will move on to the second one. So basically now this is second group. I think I have given the investigations results. So whenever you see a patient like this, kind of having severe pneumonia, then you have to request for further investigations, right, on admission, right? So other investigations. So I think I have given all these investigation results, right? So we have performed arterial blood gas, and oxygen level is 65 and carbon dioxide 50. White cell count is 22,000 and neutrophil count is 85%. CRP very high, ESR high, and the other investigations are there, right? So whenever you get a patient with pneumonia, so these are the type of investigations which we normally ask for. Arterial blood gas, right? Full blood count, CRP, ESR, and then serum electrolytes, blood urea and serum creatinine, and then random blood sugar, sputum and blood cultures, and then we will ask for a chest radiograph as chest X-ray as well, right? So now right. So then can someone from group 2 interpret these results? Number 26. The investigations results, arterial blood gas and all that. Hello, can you all hear me? 26 Nathan, 23.
Sir.
Batch rep.
Sir.
Who is number 23?
Yes.
What is your number, Darbu?
23, sir. Hello, sir.
Very good, very good. 23, right. So, okay. Right. Okay. Now, So can you interpret these results?
In the
Especially
blood gas,
the arterial blood gas, is it normal or is it
the partial pressure of oxygen is low.
Right.
And partial pressure of carbon dioxide is high. So the patient is hypoxic.
Right. So as well as
hypercapnia.
Right. Okay. So if it is more than 46, more nearly, if it is crossing 50, it is elevated, isn't it? So is it type 1 respiratory failure or type 2 respiratory failure? So hypoxia alone will be is called type 1 respiratory failure, isn't it? So if the patient has got hypoxia as well as hypercapnia,
type 2
call that type
2 respiratory failure.
Type 2 respiratory failure, because when someone is hypoxic, that patient will keep on breathing rapidly, isn't it? That will basically wash out carbon dioxide. So in this kind of a situation, we would expect to see a lower level of lower value of partial pressure of carbon dioxide rather than an elevated value. So if when the carbon dioxide is elevated, it is called type 2 respiratory failure, and you have to, it's a sort of an alarming sign in any patient with pneumonia or bronchial asthma kind of thing, right?
Yes.
So then what about the other investigations?
In the full blood count, there is neutrophil leukocytosis.
Right.
And the CRP is high. ESR is also high. In serum electrolytes, there is the sodium level is low and potassium is normal. Blood urea is high and serum creatinine is high, and RBS is also elevated.
Right. So with this blood urea level, so then what would happen to the curve 65 score? So earlier, patient was having respiratory rate was elevated, then blood pressure was low, and he's more than 65. So he scored 3 out of 4. Now blood urea is 10.
It becomes 4. It becomes 4.
So now it is become 4. So 4. So patient is having very severe kind of pneumonia. Right? Okay.
Yes.
So now this is the chest X-ray which we took. So what is the radiological diagnosis?
There is right side, upper and middle lobe consolidation.
Okay, so how are you going to definitely differentiate whether it is upper lobe or middle lobe? So what is the other investigation you have to do?
Lateral chest
So
X-ray.
so right, okay. Lateral X-ray, chest X-ray, excellent. Now in a sort of a PA chest X-ray, how do you recognize whether the middle lobe is affected? You have to check whether
there is obliteration of
the lateral border of the border, and if it is the lower lobe, then there will be obliteration of
the border of the diaphragm will be obliterated.
Diaphragmatic border will be obliterated, right? So when you take a lateral chest X-ray, this is how you are going to find out whether it is upper lobe, middle lobe, or lower lobe, right? So this is the hilar region, and then you anteriorly draw a line resembling minor fissure, right? And this is a sort of a oblique line resembling major fissure, right? Anything posterior to that will be in the lower lobe, and this is the area for the middle lobe, and this is the area for the upper lobe. This is on the right side, right? In the left side, we have only the upper lobe and the lower lobe. But when you look at the chest X-ray, if the lateral border is again obliterated, then it has the left uvular lobe, right? So always, if you have a doubt, you have to get a lateral chest X-ray, and you have to go through the lateral chest X-ray with the PA view to differentiate which lobe is actually affected, right? So you will be given X-rays like this when you come for your final MBBS end appointment oscopy, right? Simple, isn't it? Minor fissure, major fissure, upper lobe, middle lobe, and the lower lobe, right? So what are the possible organisms? Now in this patient, it looks like right upper lobe as in lower, right? So what are the possible organisms which might have caused pneumonia in this patient?
Streptococcus.
Hello?
Streptococcus pneumoniae.
Okay, that is the organism which can cause pneumonia. Anything else?
Klebsiella.
Right, Klebsiella. So what are the other gram-negative organisms you have to think about?
Pseudomonas.
Like Klebsiella. Okay, Pseudomonas, Klebsiella. Anything else which we commonly see in our setup? Pretty much similar to Klebsiella.
Legionella.
We see a lot of patients have Legionella. Okay, right? Gram-negative something coming with Pseudomonas, Klebsiella. Then think about urine tract infections which we get. Anything, any other multi-drug resistant organism which is frequently cause urine tract infections these days?
E. coli.
Another gram-negative one, E. coli, right? So you have to always think about gram-negative organisms whenever we see a patient with apical pneumonia, right? Apical pneumonia, right? Okay. So then, in addition to the routine organisms like strep pneumoniae, Haemophilus influenzae, and all that, so again we have to always think about gram-negatives whenever the patient has got right or left upper lobe pneumonia. Right? So what are the other possibilities coming into your mind when you see an X-ray like this? Chest X-ray. Right, upper lobe involvement.
Tuberculosis.
Common other conditions.
Tuberculosis.
Okay, tuberculosis we have to always think. Okay, pulmonary tuberculosis we have to always think. Anything else? Anything else other than a microbiological agent? Anything else when you see this kind of a sort of opacification involved in the upper zone? So you have to think about malignancies as well, right? Right, malignancies. So this there may be a Pancoast tumor, or there may be a tumor obstructing the main bronchus, right, causing collapse, and then later on consolidation and all that, collapse consolidation. So you have to keep about malignancy in your differential diagnosis as well, right? Okay, right. So then how are you going to manage this patient? Does that belong to the group 3 or group 2? Management part? Group 2 ආයතද කියන්න ඕන management part එක තියෙන. I don't have question.
Yes, sir.
Is it
Group 2?
Group 2 or group 3?
Group 2, sir.
Group 2. So anyone else from group 2, number 28?
Yes, sir.
Number 28? Huh?
Yes, sir.
Available, right?
Yes.
Okay. So how are you going to manage this patient?
After the admission, according to curve 65,
so
we
you
have
okay.
Severity.
Hello.
We have assessed the severity, and
So we have okay. Now we have assessed the severity. It's severe pneumonia. Curve 65. Score is 4 out of 5, and patient is ill. Patient is hypoxic. Patient is dyspneic.
yes.
So how are we going to manage this patient?
Assess the first assess the airway, and if a patient can't not clear the airway, we have to suck out secretion and clear the airway. This patient saturation in room air is low, 88, and patient is in type 2 respiratory failure. So we have to give oxygen, but high flow oxygen may be further aggravate the problem. So we have to monitor the patient and give the oxygen. Then also monitor vital parameters, pulse rate, respiratory rate.
How are you? Right. Okay. Right. How are you going to give oxygen?
Via Venturi.
To this patient.
Venturi mask.
Right. So we use Venturi mask. Normally we use Venturi mask for who?
COPD.
In our ward setup for certain kind of COPD patient. So this
COPD.
is a patient who has had only diabetes in the past. Right. This patient has not got COPD. So are you happy? What is your target oxygen level?
80.
So it has to be something like more than 95%, isn't it?
Yes.
In a patient like this, right? So if the patient is having COPD and if the patient is a chronic CO2 retainer, then you have to keep the saturation between 88 to 19. That is sufficient for that kind of a patient. But here it's a patient coming with pneumonia with type 2 respiratory failure, right? So what are the available modalities which we can use to tackle this problem in our ward setup?
Non-invasive ventilation.
So what do we normally do? Right, non-invasive ventilation. So now patient has got type 2 respiratory failure. So is it BiPAP or CPAP? So you have bi-level non-invasive positive pressure ventilation and continuous CPAP, that is continuous positive airway pressure.
It's CPAP.
CPAP or BiPAP?
CPAP.
Right. Normally in CPAP, what we do is we will keep higher pressure during inspiration as well as during expiration. But BiPAP, we keep high inspiratory pressure than the expiratory pressure. Right. IPAP is slightly higher than the EPAP. Right. So whenever you have a patient with CO2 retention, it is better to give oxygen using BiPAP rather than CPAP. CPAP is usually used to treat patients with pulmonary edema and all that. And if someone is having COPD or type 2 respiratory failure, I think it is BiPAP is better than CPAP.
Okay, sir.
Right? So what about giving oxygen with a 95% with a non-rebreather mask? I hope that you all have seen non-rebreather mask.
Yes,
it is available in our ward 11 and 12. Right. So again, the danger is if you give a lot of oxygen, this patient can definitely the CO2 can get accumulated, and then later on patient can become confused and all that. Right. Okay. Yes. So now in your SCQ type of patient, so there will be a certain amount of marks for delivering oxygen. Yes. Right. So you have done that. Anything else?
And then we have to take blood for cultures and sputum for cultures.
And then after
so
that
is investigation. So whatever the investigation you want to do, so again under investigation, in the same place you are going to write what is the investigation which you want to repeat or do, whatever it is, right? Investigation. Anything else?
After the getting blood for cultures,
so you mentioned about monitoring.
Yes, we have to monitor pulse rate,
How am I going to
respiratory
monitor
rate.
the patient?
We have to connect the patient to cardiac monitor and pulse rate, respiratory rate, and blood pressure measurement regularly. Then we have to start empirical antibiotic, IV empirical antibiotic.
Anything else? Anything else to monitor? Now these patients, the sneak and oxygen saturation was 88 on room on admission. So you have to get full marks. You have to say you want to monitor oxygen saturation, pulse rate, blood pressure, and respiratory rate. Right? Okay. Right. So then you want to start antibiotics.
Yes.
Right. So how are you going to start antibiotics?
As this patient has severe pneumonia, we have to start IV and empirical antibiotics within 4 hours of presentation, as early as possible. Not delay antibiotic until blood culture is available. We have to select empirical antibiotic depending on clinical features and investigation result. Depending on the best suspicion, we have to select as a streptococcus pneumonia. It's a patient present with typical features with rusty color disputum and then
right. So now what does the Kumar and Clark say about antibiotics in pneumonia?
We have to start antibiotic.
So how do we have to select? According to what? So if you turn your Kumar and Clark, there is a nice chart, right? And there is the antibiotics are guided according to something. So what is that? So that will be again and again asked from you all. IV antibiotics in pneumonia. Anyone else from that group? 34?
Curve 65 score.
Right. So we will use antibiotics according to the curve 65. This thing. So now this patient's curve 65. It is clinically it is 3 out of 4, and with investigations 4 out of 5. So very severe pneumonia. So what are the antibiotics you are going to use? So in the final, when you are given a question like this, don't write empirical antibiotics and all that, right? So you have to select antibiotics according to curve 65, and you have to commit and you have to say that this is what I am going to start. Right? So if you write empirical antibiotics and give examples starting from coamoxiclav to cefotaxime, clarithromycin, meropenem, and everything together, so I don't think you will get full marks. Right? But if you say this patient's curve 65 score is 4 out of 5 and this patient is having severe pneumonia, then this is what I am going to start. That is more than sufficient to get full marks. So what do you want to start according to curve 65?
IV coamoxiclav 1.2 gram. 8 hourly for 3 days.
So what do you want to start?
IV coamoxiclav 1.2 gram.
So curve 65 score is 4. I don't think it is sufficient.
And clarithromycin 500 milligram per twice daily.
Oral or intravenous. So again now coamoxiclav and clarithromycin is given when we start IV antibiotics when the curve score may be around 1 or 2, isn't it? So this patient's verbs 65 score is 4.
No, sir. It's mentioned as 3 to 5 patients.
So again, in this patient, now patient has got right upper lobe pneumonia, and we have to think about gram-negative cover and all that, right? We have to think about Pseudomonas, E. coli, and all that. So to cover them, I don't have the Kumar and Clark with me at the moment, but according to British guidelines, British Thoracic Society guidelines and all, so this patient will need something more than co-amoxiclav when the score is 4. Are you sure about this? What is given in the Kumar and Clark? Because this will be asked again. Oh, what does the Kumar and Clark say?
Kumar and Clark says, give antibiotic as soon as possible, co-amoxiclav 1.2 gram thrice daily, intravenously plus clarithromycin 500 milligram twice daily, intravenously, fluoroquinoline if Legionella disease suspected, and alternatively, penicillin, if penicillin allergy, IV cephalosporin, plus clarithromycin, or IV benzyl penicillin and fluoroquinoline.
That is for what?
That is for curb 3 to 4. And if
okay, so we right
4 to 5, consider ICU admissions.
Okay, so I have to double check that is, but again, even if we are preparing MCQs and all that, this is what we do. We always refer to Kumar and Clark. So we have to, that is the sort of a recommended textbook. So we have, whenever there is a doubt, we have to go through the Kumar and Clark. But if you say they have recommended only co-amoxiclav, I really doubt. But I will double check and I will let you know at some stage, right?
Okay, sir. This is 9th edition.
Right. So then what else do you want to do? Right. So what else do you want to do? And basically now we have to triage this patient on admission, and according to curve 65, patient has got very severe pneumonia, and this patient may even need ICU care, right? And then monitoring, we have to go by oxygen saturation, respiratory rate, pulse rate, and blood pressure. And then we have to describe how we are going to give oxygen, right? And then we have to mention about antibiotic therapy. And then this patient has got high blood sugar, right? So we have to correct blood sugar with insulin. And then we have to optimize this patient's hydration.
Yes, sir.
Right. Okay. So then we will move on to the third question. Balana product our waiting room It looks like only 86 participants, isn't it? Right. Right. Okay. Now, this patient with initial, now this is for group number 3, right? With initial management, patient's oxygen saturation, pulse rate, and BP blood pressure gradually improved, right? Even after 4 days of IV antibiotics, patient has high fever spikes, and the investigation shows a very high white cell count. White cell count is 28,000 and CRP is 312, right? So what are the possibilities? Someone from group 3, that is number 45. Number 45, Buddha.
Sir.
Oh, yes, sir. So what are the possibilities? So now this patient continues to have a very high fever spikes even after 4 days of IV antibiotics.
due to inadequate antibiotic doses and selecting incorrect antibiotic, and also due to antibiotic resistance, and patient had developed another complication following pneumonia, such as
so what are the complications this patient can develop?
Lung abscess,
So,
parapneumonic
okay, lung
effusion.
abscess. Parapneumonic effusion will not cause very high white cell count and very high CR. Anything else? Something to do with the empyema, okay, and all that, right? Okay, so we have to think about complications such as lung abscess and empyema, right? Resistant organism, right? So probably you all have started the IV coamoxiclav and oral clarithromycin. May not be sufficient for this patient. Patient may be having a sort of a gram-negative kind of organism, right? So inadequate treatment. You have to think about alternative diagnosis as well. Pulmonary tuberculosis, melioidosis, right? And carcinoma bronchus causing collapse consolidation, and then impaired host immunity as well. So this patient has got uncontrolled diabetes, but we have to think about other conditions like HIV and all that at a later stage. Now this is basically about unresolving pneumonia, right? Right. This is coming under unresolving pneumonia. So you must know causes for unresolving pneumonia, complications, resistant organism, inadequate treatment, right? Then alternative diagnosis, and then things like impaired host immunity, right? This is, so patient fever was not responding, and we have done a chest X-ray. So what does this show?
So in chest X-ray, right side upper lobe, we can see abscess
upper lobe, right side upper lobe,
abscess with air fluid level.
Right, so it looks like a right-sided upper lobe abscess formation. So you can very clearly see the air fluid level in this cavity, isn't it? Right. So this patient has developed a right apical lung abscess. Right. So this is from a different patient, but this can easily affect. Now this is very clear in this chest X-ray, but whenever you repeat a chest X-ray when the fever is not responding, this is one thing you have to very carefully look for. You have to actively, very carefully, you have to look for right abscess formation if you are treating a patient with pneumonia, right? So this is quite obvious, but there may be subtle changes in the early days, especially 4 days after commencing IV antibiotics and all that, right? So you have to very specifically look for abscess formation, right? So now, right. So what are the possible organisms which can cause abscess formation?
Staphylococcus aureus.
And yes, you have to shout.
Staphylococcus aureus.
Right, Staph aureus. Okay, good.
Klebsiella pneumoniae.
Klebsiella. Anything else?
Other anaerobic bacteria.
Right, okay, anaerobes, very good. Anything else? So if you go through your Kumar and Clark, there is a small box. Right? Right? Organisms causing lung abscess and all that. Right? So you have to things like, especially in this patient, you have to think about Klebsiella, E. coli, and Pseudomonas, right? Because this patient has got right-sided upper lobe pneumonia. So gram negatives, you have to always think about gram negatives when someone is present with right upper lobe pneumonia, right? So in addition, other organisms which can cause lung abscess are Staph aureus, Streptococcus miller, Acinetobacter, anaerobic bacteria, Haemophilus influenzae, and Mycobacterium tuberculosis. So now this list is given in a separate box in your Kumar & Clark, right? You must know you must know all the names, because this can be easily given as a sort of a true and false type of MCQ, right? So gram-negative, Staph aureus, Streptococcus miller, which is something you have to remember, Acinetobacter, anaerobes, Haemophilus influenzae, and tuberculosis as well, right? So how are you going to manage this patient? Lung abscess.
Treat antibiotic with clindamycin plus cefuroxime.
Okay, right. Okay, you have to always you have to get the sputum cultures, and according to that, you have to change the antibiotics, right? And before that, you have to think about Staph aureus. You have to start. You have to give something to cover Staph, and then you have to give something to cover Streptococcus and Klebsiella and all that, and then you have to give antibiotic to cover anaerobes as well, right? So other important thing is you have to guide it by the sputum culture report, right? In this time, this patient actually ended up having Klebsiella, right? So we had to change over to carbapenem and all that in this patient, right? So then what are the other measures, right? Antibiotics. So you have to cover all the organisms, and then depending on the culture report, you are going to select a particular antibiotic. So how long are you going to continue?
We can wait for about 4 to 6 weeks.
Right. So we have duration antibiotics altogether, IV oral, right? It has to be something like 4 to 6 weeks. Usually it is 6 weeks. So we can always get advice from microbiology team, right? Antibiotics. Anything else?
If there is failure to respond, we can consider surgical drainage of the lung abscess.
So how are you going to surgically drain that? So how are you going to drain this lung abscess? Surgically means?
Don't know, sir.
So open lung surgery, or what do you want to do?
Not open.
So then how are you going to do that? So now again, can you drain this? Can you put a needle through the chest hole and drain this? Yes or no?
No, sir.
If you drain this again, now we can drain if something is collected in within the pleural cavity, right? So by doing that, we are not going to damage the lung, right? Basically, if there is no pleural fluid, we are not going to drain, or we are not going to do a thoracentesis, so we are not going to do a pleural biopsy, right? So now lung abscess is different from pleural effusion. Lung abscess is something within the lung parenchyma. So in a sort of a transthoracic way, you are not supposed to drain that. So if you do that, you can create a fistula. You can create a fistula formation. You can cause a lot of problems to the patient, right? So lung abscess, basically, you are not going to drain in a sort of a transthoracic pattern. So any other way of taking this yucky material out? You can get the physiotherapy department help from physiotherapy department.
Yes, sir.
So what do you want to arrange? Limb physiotherapy or something else?
Chest physiotherapy.
So you do chest physiotherapy and postural
Drainage.
right. Chest physiotherapy and postural drainage, right? So antibiotics for a long period, and chest physiotherapy and postural drainage, right? So again, now you have to optimize this patient's diabetic control, and then we have to think about arranging further investigations like bronchoscopy or CECT chest. Okay, right.
Okay, sir.
Right. Right. Can I move now? Shall I move to the fourth question? Right? Can someone from the fourth group, number 67, is that person available? At a hatha. 67. Nathan 77. Lucky number. මේක වෙලාවත් ඉවර වෙලා දැන් ලර්න් කාර්යය මේක වහලා දාවිදා ටික කියනවා. I have booked only for 2 hours. Number 77. Next time, first of all, I will get a sort of a name list, and then I will mark attendance as well before starting this meeting. Hathat ne the monitor of the batch rep 71. Hello.
Hello, sir.
Hello. 71. Something has happened. Right. Anyone from group 4?
Hello, sir.
Ah, right. Can you answer the question? Right. So, what is your number, Puta? ඔගොල්ලෝ කතා කරේ නැත්තම් මම මෙහෙන් කෑ ගහනකොට නිකන් මම කෑ ගෙදර මිනිස්සු බලනවා. Hello.
The most likely diagnosis 71.
I didn't get you clearly. Can you all hear me clearly? Are you number 71? Right. So this is a chest radiograph of a 66-year-old man who was getting treatment for right basal pneumonia, right? And he has been getting treatment for about 5 days. And then even on day 4-5, he was febrile and ill-looking, very high white cell count, and CRP is 312. So what is the most likely diagnosis? Hello. Right. Can you all hear me clearly? Monica, can you, Batrep, can you respond, because I cannot hear her clearly. Huh?
Yes, sir. Yes, sir.
Right. Now, alien can kata karna hoga. There's something wrong with the internet connection. Anyone else from that group number 4? Hello. Ah, right. Uda, what is the most likely diagnosis?
I think it is empyema.
Right, empyema. So why do you think it is empyema?
Because the pleural aspiration shows its appearance is cloudy, and pH
clinically by now. So we have to do left aspiration later on, right? So, but in this patient has got very high white cell count, CRP, looking, and there is right side, there is evidence of right-sided pleural effusion as well, right? So if someone is having very high white cell count, very high inflammatory markers, then you have to always think about empyema, right? So this is the pleural aspiration fluid results, right? So can you comment on this?
Appearance is cloudy, and pH is low. It's less than 7.2, and there are high polymorphonuclei, and LDH level is high, and sugar level is also low.
So this looks like empyema, right? So now number 1, now I haven't put a slide on that. So now whenever you are given a pleural fluid analysis report, you have to find out whether it is exudate or transudate according to Light's criteria. right? So now in this patient's pleural fluid, it's definitely sort of a exudative kind of thing, right? So in this patient, now what is the next step in management? How are you going to manage this patient?
To do a ultrasound scan, chest.
Okay, so ultrasound scan confirms that there is a thick kind of pus kind of thing in the right pleural space. So whenever you see a patient with empyema, so what is the next step in management?
CT chest.
Okay, CT chest, and again that would again confirm the diagnosis of possible empyema. So what is the next step in management? So that is what people are going to ask when you sit for your common MCQ paper. So if you have a large abscess in your hand or in your thigh, so how surgeons are going to deal with that?
Aspirate the.
So you have to aspirate, right? Okay, so in this patient, if there's something, if there's pus inside the pleural space, how are you going to manage? So this is different from your lung abscess. Lung abscess, it is within the lung.
We can drain it with intercostal tube.
Right. Next step in management is you have to arrange a intercostal drainage. Now there are indications to put a IC tube. Right? There are indications to insert a IC tube. Mata පොඩ්ඩක් නවත්තන්න වෙනවා. Right, I am getting a phone call. This will be interrupted by several phone calls. මම පොඩ්ඩක් ඒකට answer කරලා I will come back to you, right? Just hold on, මම මේක පොඩ්ඩක් mute කරනවා. Hello. Hello. ඇහෙනවද දැන්?
Yes, sir.
Right. Okay. So you must know the indications to put a IC tube when you are suspecting empyema. So now pH is less than 7.1, right? Very high polymorphonuclear counts, and if you are raining pus kind of thing from the pleural space, right? If the LDH level is very high, the random blood sugar is low, and then the culture is positive and if the gram stain is positive, so those are the indications to put a IC tube, right? So you have to, at the end of this, you have to read somewhere about indication to put a IC tube, and then you have to write down those indications. Right. right? So this is the next step in management, and right. Okay. Now, when you look at a sort of a diagnostic dural aspiration, right? So you can differentiate, you can categorize it as simple parapneumonic effusion, complicated parapneumonic effusion, or empyema, right? In a sort of a simple, can you all hear me?
Yes. Yes.
Right, okay. In a sort of a simple parapneumonic effusion, fluid is clear and there will be a polypropylene. Hello?
Excuse me, sir. Some of our batchmates have disconnected because of the poor connection. Sir, they are trying to connect it again, but you have to accept them. Hello?
Now you all can see here there are about 79 participants. No one is trying to. I think there is a problem with this learn network and all. So do we have to invite again?
They are trying to connect. So what should I do? Okay, mekan තේරෙන කෙනෙකුට මේ කියන්න පුළුවන් මම මොකද්ද කරන්නේ දැන් මේ ස්ක්‍රීන් එකේ කියලා. So there is something called manage participants. Yeah, chat, record, hide, floating. මේකද new share කියන එකද මොකද්ද මේ? කාට හරි අනේ තේරෙන ළමයෙන් මේක මොනවද හරි කියන්නකො මේක කරන්න ඕන මොකද්ද කියලා.
So I think in the participant icon there may be a message showing admit this like
So
participants.
එහෙම එකක් ඉන්නේ නැහැ නේ මේකට. නෑ admit වෙනවා නම් මෙතෙන්දී නෙන්නේ.
Yeah.
මෙතෙන්ට appear වෙනවා admit වෙනවා. So what is that? Right, then this is invite. Copy invitation. මේ දරුවනේ මේක නම් තේරෙන්නේ නැහැ නේ. මේකද copy invitation කියන්නේ මේකද? Hello. දැන් ඔය ටික ඔක්කොම chat box එකට ඔක්කොම දාලා ඉවර වෙනකොට වෙන්නේ මොකක්ද දන්නවද? පැය දෙකකින් මේක ඉවර වෙනවා. ඒකෝර මට මගදී නවත්තන්න වෙනවා. අයියෝ. copy URL. එක කොහෙට යනවද කියනවත් දන්නේ නැහැ දරුවෝ. ඊට පස්සේ ඊමේල් එකට ගිහිල්ලානේ ඊළඟට බලන්න ඕන. So So there is no one waiting actually.
So maybe you can continue it and we can share it with others later.
So some of us are recording the screen, then we can share it
right.
with the others.
Right. එහෙම කරන්න ලේසි නේ නැත්නම් මේක හරියන්නේ නැහැ නේ. Right. Okay.
The batch reports are not here now.
දැන් ඔයගොල්ලෝ කියන ඒවත් වීඩියෝ කරනවද නැහැ අයියෝ මන්ද. Right. Okay. ඕක දාලා ඉවරලා ඔයගොල්ලන්ගේ එක ෂෙයා කරන්න හොඳද? මේක මේ විකාර ඔක්කොම වෙනේව දාන්න එපා වෙන මොකකවත්. ඉතින් මම එතකොට මොකද්ද කරන්නේ? Shall I start it again එහෙනම්? Shall I quickly arrange something now and shall I send that across? Make an navattala. Hello. Mama make a navattala.
Yeah.
Mama make a navattala එකක් හදලා batch rate එකක් ගාලා එවන්නද? ඔයගලන්ට ඉක්මනට කරන්න පුළුවන්ද එතකොට?
Okay, so we can.
හරි එහෙම කරමු අපි. Right.